Hi, this is Dr. Joel Yaffa, family doctor, and your chairman for the BHRT World Summit 2. The Bioidentical Hormone Seminar is meant to give the public a wide perspective of what physicians are using to treat patients using bioidentical hormones, the different medical conditions, and the ways of delivering the hormones. Today we are very, very fortunate to have with us Dr. Gino Tutera, a board-certified obstetrician-gynecologist practicing in Scottsdale, Arizona. He wrote 2 books, You Don't Have to Live With It and Life Regained, and has a tremendous following. People fly in from all over to be treated by Dr. Tutera. He has a special way of delivering his hormones that makes the treatment very effective. So I'm so happy that he has agreed to speak with us and to tell us about his treatment. Thanks for being with us, Dr. Tutera.
Thank you.
Can we start off and tell us how you got involved in bioidentical hormones? It's not usually taught in medical school.
No, actually, my introduction to bioidentical hormone replacement started 30 years ago, and it really started in my obstetrical practice when I noted that a number of patients were losing what appeared to be viable pregnancies, and it was to me curious that we had never ever thought about checking hormone levels on the individuals, and at that time I started checking progesterone levels in early pregnancy and found that progesterone deficiency was one of the key factors for pregnancy loss. Back then I was uncomfortable with the usage of synthetic progesterone, and happened to find a compounding pharmacist who was one of the real trailblazers in the area of compounding, and he introduced me to the usage of bioidentical progesterone, and we utilized that in various methods, and came upon the fact that if we used a certain dosage of progesterone in pregnancies that had low progesterone and had experienced some signs of loss, such as spotting or uterine cramping, we treated them with progesterone and saved a great number of those pregnancies without any adverse effects on the fetus. And it just made sense to me that if we're going to try and treat people for hormonal deficiency, that you should utilize a hormone that is going to be identical in structure to the one that is deficient. So that started my journey on bioidentical hormone replacement, which was followed shortly thereafter in treating premenstrual syndrome and menopausal individuals with compounded hormone. With the continuance of that practice, I saw great success with little, if any, adverse reactions to individuals, especially compared to the present synthetic hormone that was on the market, as well as the conjugated estrogens of horse origin. And I felt very much resolved from that point on to follow that path for health for my individual patients. And as I was going through these years of utilizing bioidentical hormone replacement, I was firmly convinced that the methods of delivery weren't ideal. And this led me to discover the usage of subcutaneous pellets. These are small rice-sized pellets that are inserted underneath the skin. And the reason I used these and became firmly convinced that this was the method of choice is because this is the only form of hormone replacement that the body can actually control the release of the hormone through the action of the heart, as well as be able to individualize the dose for each particular patient, and thereby giving them uninterrupted serum levels of hormone. Being able to maintain a continuous blood flow and maintain a continuous level of hormone reapproximate what the human ovary and the human testicle would do for each human being. If in fact we're able to truly do bioidentical hormone replacement, I felt that certain parameters had to be met. Number one, not just give bioidentical hormone replacement, make sure that it's in the proper ratio, which I'll hopefully get to in better explanation. Thirdly, a delivery system that works as closely as to what the ovary and testicle would normally do, and being able to individualize the dose to each particular individual is extremely important, and then proper follow-up. So if you're really going to do bioidentical hormone replacement, I think these are the parameters that need to be looked at. And the only method of delivery that allows us to fulfill all of those parameters essentially, and as they should, are the usage of subcutaneous pellets. The pellets work on a dissolution constant that is tied to the human heart rate, so that the faster the heart rate, the body becomes like a child licking a lollipop, so that you get a quicker, faster release of hormone during periods of anxiety, stress, exercise, and a much slower release during times of calm, such as meditation, reading, watching television, or sleeping. And each of those different levels would demand a different level of hormone. And you can't achieve that by using oral or patch or creams or injection, or the more, of all the typical forms of hormone delivery cannot deliver continuous levels of hormone appropriate for each particular stage of that person's daily activities. So I became most interested in the effects of these hormones being delivered by pellets, and researched the literature, and dating back to even 1937, there have been articles about subcutaneous pellets, and as I continued to research, I found out the great benefits that it has for cerebral function as well as cardiovascular protection.
Well, I think that it's actually brilliant the way that you're doing it, because when I give my patients their hormones by mouth or by cream or by patch, I have to teach them how to adjust it according to what their situation is in life. And I tell them that the more stress you have, the more you're burning up your hormones, and you need to take more. That's why the hot flashes came back, because they can identify stressful things that happen to them. And other times, if they would still take the same regular dose and they're more relaxed, they would have symptoms of having too much hormones. They would have swelling and breast tenderness and things like that. But it sounds like using these pellets is self-adjusting, that the body is as if the ovaries or the testes were making these hormones themselves, would be getting the right amount for the situation that they need. I think that's brilliant.
Well, that's the beauty of using these, is that it becomes less problematic for the patient, as far as how he or she does not have to adjust hormone, put on more cream, put on a patch sooner, use a combination of products to try and adjust for the daily stresses and strains that we all are subject to. And when you tie this to an internal organ system to control the release of the hormone, it basically, the body once again is in control of hormonal release, much like it was when the ovary and testicle were working at their peak efficiency. And we can't recreate that with external sources of hormone delivery, such as the pills, patches, and creams. It's just they're all tied to a peak and valley pharmacology, depending on the agent or delivery system that you're utilizing. Whereas with the pellets, it's because of their construction, because of their lack of any extingencies or binding factors, which makes our particular product, the Sotopelli pellet, that much, is basically as pure a form of hormone as you can potentially, create. So therefore, because of the research that's gone into creating these pellets, it allows them to work almost seamlessly, and it's the patients. You don't have to worry about differences in absorption or in any way some sort of variable coming into play that might change the effect. Whereas when you get compounded hormone made by your compounding pharmacist, if the patient should have a batch made by a different person, there may be changes in even though the formula is the same, there may be certain changes that might be expected. And we found that even with progesterone being compounded in different pharmacies, there is different absorption, there is different reaction, and so therefore we kind of stick to one particular pharmacy, and our pellets are basically created basically uniformly, so that I don't have to worry about whether patient A or patient B is going to get the same level. I know that's going to happen depending on what their cardiac output and heart rate are.
Is there a special way that these pellets are processed? How does the compounding pharmacist make your Sotopelli pellets different than if I would order them from a different compounding pharmacist? It sounds like you put a lot of energy into how these come out.
Our pellets are specifically formulated according to the formula that I've put together, and in addition to that, the pharmacy that I've been using has been doing and making pellets for almost 45 years. The experience that they have, is something that can't be replaced, because they've been through all the wars. They understand, the potential for variability that can be thrown into it. Because I've tried a number of pharmacies, and I unfortunately have not, up until I found this particular compounding pharmacist, I did not find a consistency from one lot to the next. And the particular pharmacy that I use has basically been mandated to take a certain sample of each lot to be sure that the purity and the consistency are exactly identical from lot to lot. And there are very few, if any, other pharmacies that do that. They usually put pellets together, assume that they have the same consistency and the same basic chemistry. And unfortunately, I, through trial and error, have found that isn't so. And that's why if you go to a compounding pharmacy, they can put a pellet together, but if they don't do it with the proper firmness, if they do it with a lot of binding factors, which can prevent absorption, you may get too rapid of absorption. You may not get any at all. The pellets may dissolve quicker or slower than you had anticipated, and you get very, very variable levels of hormone, and that can basically destroy the confidence that your patient may have in the employment of hormone delivery. And you find yourself becoming discouraged, and you go back to what feels comfortable for you, which is pills, patches, or creams.
Actually, physically, how do they make a pellet? They put the powder of the hormones and they pressurize it, or do they cook it in a way? How do they actually make it look like that?
Those are trade secrets that they won't divulge, so I can't divulge it to you either. They just leave it to say that they're done under sterile conditions, and different pellets are made with a different manufacturing process, depending on whether it's male or female pellets, and the ones that we use, that we have are, especially in the area of testosterone, are unique in how they're manufactured, and they basically, there is no other pharmacy. Maybe there might be one, but basically I know of no other pharmacy that has the capability of employing the different forms of of construction that they have, and it's a very one particular form is extremely delicate to do, and if you don't have expertise in that, you can just ruin batch after batch of hormone.
Which hormones do you use in the pellet form?
For estrogen, I use exclusively 17-beta estradiol. That basically is the workhorse estrogen in of the human female. The testosterone that we utilize comes from the beta nucleus, because the alpha or alkyl nucleus is what comprises the synthetic anabolic steroid testosterone, and causes a significant amount of problems with liver and heart. And the usage of aromatizable testosterone, I feel, is mandatory for my practice, and I use exclusively the 17-beta estradiol and the aromatizable testosterone because of the fact that it is exactly what the human body produces.
Mm-hmm. Can you explain to everybody what does it mean, aromatizable testosterone?
Is there a difference in the aromatizable testosterone?
No, just the phrase. It's not something that everybody understands about aromatization.
They may not, because the way we're taught, the way we're instructed, is primarily along the lines of what the pharmaceutical industry gives us access to. That information basically deals with the products that they particularly produce. The majority of the world's literature is, as far as the effects of testosterone on individuals, both male and female, is usually done with with that particular non-aromatizable testosterone, which can have some rather serious side effects, especially as far as the attacking of the myocardium, the elevation of serum lipids, the particular problems that it has with androgenic side effects for females because of its creation of its basically breakdown into dihydrotestosterone, whereas aromatizable testosterone is the same testosterone that the human ovary produces and then aromatizes to estradiol. In the human male, we know that we also aromatize it as we get older. So this is the type of testosterone that is inherent in the human male and female. And unfortunately, we've been using a form of testosterone that is, absolutely foreign to the human physiology.
Okay. Thanks for the explanation. Do you give female patients estradiol and testosterone, or you give them just one? And male patients, do you give them both also?
The female patients, testosterone, one of the things that I've found in the physicians that I've trained is, unfortunately they come in with a complete, a rather complete ignorance of what human testosterone its place in the human female physiology. And unfortunately what happens is that we don't even know, when I ask the question, how much testosterone does the human female make in the premenopausal time, the answers that I receive are completely, I haven't gotten one right answer yet, because I give them a multiple choice question, and because of the inaccuracy of the assays that we've used, over the past, few decades. These assays have led us to think that human females make very little testosterone, and in fact, in the journal Fertility and Sterility, a group from Princeton basically studied the assays and found that they are unreliable below the level of 300. And we've been telling women that the level of testosterone in our labs will range from 6 to 82. And that basically is nanograms per deciliter. If, in fact, the assays can't measure anything reliably below 300, then we don't have a good norm for women. And what I've found is that, and the research proves, women in the premenopausal state make 300 milligrams of testosterone daily. That's a large amount of testosterone. I think as we know, 50% of that goes for estrogen production, but we still have this other testosterone that is important for muscle maintenance, for the creation of bone, for the activation of hepatic lipase to break down cholesterol, to help us activate HDL, to help brain function, and we'll get into those as we speak. But women need testosterone to survive, and to survive in a functional manner. Males, we make testosterone as we age. We aromatize testosterone as we age into estradiol, but unfortunately what happens is that when we aromatize too much, it becomes injurious to our prostate, because it also affects, as the estrogen rises, it also affects our metabolic breakdown of glucose. And as the estrogen rises, we unfortunately produce more sex hormone binding globulin, and as that estrogen continues to rise as we age, the sex hormone binding globulin binds up the free or active form of testosterone, and we are left with a less functional state. And unfortunately, we tend to think that as long as we smear a cream on or put on a gel and get a rapid spike of testosterone, that's all we need to do. We need to recreate the consistent, steady levels of estrogen and testosterone in females, and that steady level of testosterone in males, to be able to affect the benefits of brain in the area of brain function, musculoskeletal function and integrity, the affect metabolically on lipids, which helps us protect our cardiovascular system. And if you don't have a steady flow of hormone, you're not really reproducing a physiologically normal state. And that really should be our intent, is not just to give biologically identical hormone, but to recreate normal physiology. And that's where we basically fall down, is that we give hormone on the premise of symptoms and the relief of symptoms, but what we should be doing is not only relieving symptoms, but making a person physiologically normal, so that we can once again reestablish cardiovascular protection, normal brain function, protection of our metabolic well-being in the area of glucose and lipid metabolism, as well as our structural system of maintaining muscle and creating bone. So I firmly believe, and the research backs me up, is that the usage of pellet hormone, especially in the area of osteoporosis, the studies done by Dr. Studd in England in 1990 and 1993, the last one being published, one in obstetrics and gynecology, the other one in the British Journal of Hospital Medicine, showing that usage of pellets will increase bone density 8.3%, whereas oral forms of estrogen will only increase the level of bone density by 1 to 2% at best, and even patches maybe 3%. 8.3%, and I've seen this in my own practice, that it's not unusual to see bone growth from anywhere from 6 to 10% per year in individuals that come in with osteopenia and osteoporosis. So I'm firmly convinced it's the continual presence of that hormone that affects that, whereas when you have sporadic peaks and valleys, you cannot maximize the benefits of the hormones that you're using.
Is there anything special about these hormones and brain function that we can add, except that it's good for it? Are there other than neurotransmitters, serotonin, dopamine, any of these related to these hormones being normal or abnormal?
As far as brain function, without the continual presence of estrogen, the ability to make the neurotransmitter acetylcholine, it basically falters. In addition to that, you can't, in the serotonin-producing nuclei, you need that continual stimulation of estrogen to help produce the serotonin, that you need. That's why so many individuals, especially females, are placed on, the serotonin reuptake inhibitors, because as their production of serotonin decreases, we're trying to maintain that, that level by not allowing it to be destroyed. So what we want to do, if we could really think about it, why not increase the production or maintain the production as high as it was in the premenopausal state? And to do that, you need a continual presence of estrogen, and specifically estradiol, stimulating the serotonin-producing nuclei. Neurotransmitters, especially acetylcholine and the others, are very dependent on the presence of estrogen. And if you're only getting sporadic levels of estrogen in the brain, you're going to get sporadic production of neurotransmitters, which also I have the most common complaint that people come to see me for is I can't concentrate, I can't think, the ability for me to multitask has been altered. I'm having trouble keeping up with with my younger associates because of the fact that I can't think. It takes me longer to do problem solving, and I can't remember. And if you will give me a second, I can tell you that also steady testosterone levels, continually steady testosterone levels in both men and women affect the parietal, temporal lobe, and also areas in the frontal lobe. In the parietal and temporal lobe, it helps us focus, it helps us concentrate, it stimulates short-term memory. As you know from the literature, men who are low in testosterone have 3 times the incidence of Alzheimer's, and that's because of the lack of stimulation being there continuously. Nutrients and blood supply are denied, and amyloid is more likely to be deposited. So therefore, if in fact we think about just sporadic usage of testosterone, and if it's unfortunately of a non-aromatizable form, we may be encouraging brain dysfunction rather than encouraging good brain function, because it's the continual presence of these hormones in our brain and brain tissue stimulating the receptor sites that helps us with focus, concentration, the ability to have good short-term memory, have good recall, and have a wonderful attention span. I can't tell you how many patients come in to see me who are on drugs for adult onset attention deficit disorder. The majority of them have low testosterone. We place them on testosterone and get them off the drugs, and they have as good a function as they did on the drugs. So I'm firmly convinced that we are not looking at some of the very basics in human physiology to try and reverse the changes that come with, we call it aging. But in actuality, aging starts when we stop producing the amount of hormone that we did when we were in our 30s.
Do you give men estradiol pellets to help them with their cognition, with their thinking ability, or with their moods, or is it just testosterone for men?
Testosterone is the primary driving hormone for the production of short-term memory, focus, and concentration. So those day-to-day activities are affected, both men and women, by the way, are affected by the loss of testosterone. And as you know, starting at age 30, men will lose anywhere from 1 to 3% per year. Women start losing the mid-cycle bounce that they get in testosterone, and then production decreases in the ovary from that point on. And as that testosterone decreases, we take for granted that as we lose our short-term memory, that's an acceptable thing to expect. When in actuality, I have seen people who have regained all of that function, have become much more functional in their everyday lives, in business and at home, and no longer question whether or not they're getting Alzheimer's or it's early dementia. And the usage of estrogen in women also has been shown to forestall or decrease the incidence of dementia. So the usage of estrogen in women is also so very important in maintaining normal brain function in the female. In men, it seems that testosterone is the only hormone that we utilize and need to be able to do that. And I would add to that in certain receptors in the brain that the testosterone is probably converted to estradiol for the effect that women get with the estradiol that they use. So I think that is the mechanism that we men use to make the estrogen we need to help us with neurotransmitter and serotonin production.
Great, that's a great explanation. Do you get patients that come to you already on lots of psychiatric medicine and they've heard about you and you give them the pellets and they don't need their medicine anymore?
The patients that have come to see me that have been able to decrease or eliminate the medications, the most common forms are the patients who've come in with some sort of a depressive state, that or some state, the state of not being able to think as clearly, which causes a lot of frustration. I see a lot of these patients coming in on the serotonin reuptake inhibitors in the Prozac families, also as well as the drugs for anxiety and drugs for attention deficit disorders. Those patients, as they go through the therapy, start decreasing the amount of drugs that they're using. Some are able to eliminate them completely. A good majority of them reduce the number of medications or the amount of medication that they take, and that's almost a certainty in about 70 to 80% of the patients. There are going to be some patients that what they're on may not be able to be eliminated, but it works better. Because if you think about it, medications work better when there is a normal internal physiology present, whether it be vitamins, whether it be calcium supplementation, whether it be medications. If we have a normal physiology, the medications that we utilize to keep us going and keeping us healthy really have a better chance of working, rather than giving medications to patients who have an abnormal physiology. You may not get the same predictable response that you normally would. And I've seen that over and over again. And I attribute it primarily to the fact that once you've recreated this normal physiological state, that the things that they're using, such as the calcium for bone density and the vitamins for energy and the medications to keep their blood pressure more normal, basically become to work better, to where they may be able to decrease some of these cardiovascular medications, especially the statins. It's been proven to me over and over again in my own practice and in the literature that the usage of testosterone activates HDL, activates hepatic lipase, and drives down the total cholesterol. Also, the increased utilization that testosterone has on the uptake of glucose decreases triglycerides. The insulin levels that patients are carrying, especially the ones with metabolic syndrome or the type 2 diabetic, testosterone allows the muscle to uptake glucose more quickly. It allows it to be metabolized faster. Therefore, the patient starts lowering their insulin needs, and I've seen it even in the diabetics that I treat, even the ones that are type 1 insulin dependent. They've been able to decrease their insulin needs. The patients on oral hypoglycemics have been able to decrease their medications, and as their insulin levels decrease, their fat mass decreases, the insulin resistance decreases, and their lipid profiles become better, which enhances cardiovascular protection. In addition to that, they start experiencing weight loss from loss of fat mass if they're doing proper diet and proper exercise, and these individuals then are able to, in essence, decrease that metabolic abnormality that has led them to metabolic syndrome or type 2 diabetes, and speaking specifically about insulin resistance. And we've even seen that in some of our patients who are polycystic ovarian syndrome who come in with significant insulin resistance, a small amount of testosterone in association with using something such as metformin has basically transformed their lives. They're able to exercise with with results, and they get and it helps lower their insulin resistance, which when combined with metformin works for much better than just the usage of metformin alone.
Well, that's unbelievable. You give ladies with polycystic ovaries testosterone pellets. When we find that these people have elevated testosterone levels that cause acne and facial hair and scalp hair loss, the pellets cause them to metabolize their sugar better and have better control of their metabolic syndrome, which improves everything. Is that what you're saying?
Yes, in fact but on these patients you have to be judicious in the amount of testosterone that you give. A lot of the patients that come in that have elevated levels of testosterone, the insulin resistance is basically causing them to change that into more of a molecule like dihydrotestosterone, where they get a significant amount of androgenic effects, hair loss, facial hair, acne, and those things. And if you are combining metformin with a small amount of testosterone, then you're actually getting the maximum benefit that you're trying to achieve in reducing their insulin resistance. And so it's that what you're trying to. That's what the testosterone does. Is it helps augment the effects of the metformin in the fact that it helps uptake glucose much better. It helps affect those insulin levels in a much more positive manner, so that you don't have as much resistance that you have to combat in that particular individual.
Mm-hmm. Okay, that's great. Do you have any experience, since we were talking about brain function, and you said that people that come in with antidepressants oftentimes can lower their amounts and many times get off of them. Do you have any experience with using this therapy with patients that have manic depression or obsessive compulsive disorder or even schizophrenia? Any thoughts of these hormones and the normal physiology that you're giving them with the pellet therapy, that they are able to see improvement in those illnesses also?
I haven't really had any experience with patients that are schizophrenic, but I have had patients who are, I have a lot of patients that are bipolar that come in to see us, and by eliminating some of the anxiety and irritability that comes with hormonal deficit, they've been able to, with their medications, have a much better response to the medication that they're taking. I'm very wary about discontinuing, medications in any bipolar patient. I don't think that that's really, something that should be done, especially under my direction. It should be done, in conjunction with psychotherapy and allowing us to work in concert to help that patient. But if I can help eliminate some of the things that are causing anxiety, irritability, and adding to the depressive state, then I'm helping the medication that they're on work much better. Usually, in the bipolar individual, I don't see them ever getting off medication, but certainly the medication that they use may be decreased in amount, but with the same effect as when they were at a higher dose. And that's what I see in those individuals, is that not that they're able to discontinue medication, but the medication that they're using and at the dosage that they're using, they get a much superior effect from it.
Okay. If we move into how these hormones are helpful for the heart, I once read that the heart has more testosterone receptors than any other part of the body. Cardiologists aren't using testosterone. It sounds like they should be.
I've trained a few cardiologists now who use testosterone. One particular one is an interventional cardiologist in Toledo, Ohio, and he started researching the usage of testosterone in males who have chronic congestive heart failure. And what he found is that the administration of testosterone increased their ability to do work on a treadmill. And he would give them testosterone, and a few days later they'd come back in and do another treadmill, and their ability to work was enhanced. This was even in some of the literature, but it's the older literature. What I found is that, and through his feedback, is that basically he's now been using pellets on men, almost exclusively on men with chronic congestive heart failure, and has increased their work output. Their cardiac output has gone up, the ejection fraction has increased, and the amount of medications that they've needed to correct their failure has decreased. There are studies in the literature by Zamuda and his group, as well as a group from in the Chinese Medical Journal. The authors are Wu and Wing, in which they utilized testosterone in individuals who had coronary artery disease, and found that they actually get anti-anginal effects on individuals with aromatizable testosterone, whereas with synthetic testosterone, you universally get vasoconstriction. So aromatizable testosterone, not only does it increase the inotropic effect, the contractile strength of the heart, it also has an anti-anginal effect on the coronaries, to where you get pliability and elasticity enhanced in those individuals that have some residual pliability remaining. So it has a dual benefit in cardiac muscle, as well as the coronaries themselves. In the aspects of decreasing the incidence of heart disease, the effects of testosterone and estrogen are primarily on the lipids, and if you can decrease lipid and activate HDL, which we all try and do, like specifically with the statins, you get a reduction in the chance of heart attack and stroke. Well, estrogen and testosterone, when it's present continuously, helps activate HDL. Specifically, testosterone activates HDL, promotes HDL2 and 3, and it promotes also the activation of the hepatic lipase enzyme, which helps break down cholesterol and the low-density lipoprotein cholesterol, therefore decreasing the amount of circulating LDL in the blood. Without that stimulation, then we get this gradual, continual rise in our lipids, which we as physicians say, well, we keep telling patients, well, your cholesterol is going up a little higher every year, and when we get to a certain level, we'll put you on medication. It seems to me that if we can be more intelligent and diagnose the testosterone deficiency and lack of production that's occurring in both men and women, we're going to be able to hopefully decrease the amount of circulating low density lipoprotein cholesterol, the LDL, and help enhance the more normal physiology of having a low total cholesterol, low LDL, high HDL, and with an HDL that is activated to work at its peak efficiency. Because if you don't have testosterone activating the HDL, you may have what looks to be a very good HDL, but it may not be doing the job because it's not as activated as it should be. And it's the testosterone that assists that. As we know, estrogen helps maintain the intimal integrity of the vessel and increases HDL. But if you don't have it there all the time, then you can't possibly think that you're going to have that cardiac protection there all the time. And so the sporadic usage, and as you've seen in some of the studies, when you use oral conjugated estrogen, you may not be getting the cardiovascular protection that you would anticipate, because the hormone is not there at the appropriate level continuously. And that's where the soda pellet pellets become much more important, in that by maintaining steady, continuous levels of estrogen and testosterone, you're going to be enhancing cardiovascular well-being, so that the good diet that you use and the moderate exercise has the capability of being as effective and as protective as it was when you were in an earlier stage of life.
What kind of side effects do patients should they expect if they're using pellet therapy?
Well, if it's done appropriately, and when I say appropriately, if it's individualized for the particular individual, we get very few problems with patients. Unfortunately, there are people even in the area where I am now who, because of my success, have basically tried to piggyback on to using pellets, and they basically don't individualize the dose. And when that happens, you can get into the syndrome of tachyphylaxis, where they get excessive estrogen in their system, which promotes the redevelopment of symptoms that would be you would correlate with low estrogen, such as hot flashes, headache, and those, and on. And if you don't do appropriate blood work to see which you have, then you're going to continually overload the patient with estrogen. If you individualize the dose, follow the blood work as you should, then you're not going to get into those problems. So that you may get the occasional patient with some breast tenderness that comes up, but that's these days is even becoming more rare with us, because we keep refining what we do and how we do it, so that we can eliminate some of the nuisances, such as getting some breast tenderness, which is pretty rare in our practice now, and but unfortunately becomes quite prevalent in the patients who are overdosed with estrogen from practitioners that are not applying the principles that I teach.
What about women developing acne or facial hair? Is that an issue with the pellet therapy?
Well, any usage of testosterone might do that, but we've limited the occurrence of that by individualizing the dose of testosterone to that particular individuals, and we have certain parameters that we utilize. Not only that, but after the initial therapy has been utilized, we may alter the dose depending on what the response is that we see in the lab. And so if you're just giving testosterone and not monitoring the effects, and that's done very commonly, especially with creams. Nobody goes and measures what the effect of that cream is 2 or 3 hours after application. And in one individual who came in complaining of acne, her testosterone was well over 700, 2.5 hours after application of the quote-unquote female dose of testosterone, which was about maybe a small 1% concentration, which is commonly used in the United States. And we found that her testosterone a few hours afterward, there isn't a woman in the world that isn't going to break out or have some sort of an adverse epidermal reaction when their testosterone every day or every other day is raised to well over 700. So we need to be more intelligent as physicians and really understand what we're doing with what we're using. And to do that, you need to get blood work. So if the maximum absorptive time for your cream is between 2 and 4 hours after you've applied it, then why not do it once and measure and see how high that testosterone gets. The patients who don't peak up very highly will probably have less chance of having that problem. With pellets, once you get the initial rise, the patient then plateaus and keeps at that low level of plateau throughout the life of the pellets, and augmentation of that level every 4 to 6 months with the appropriate dose of testosterone doesn't lead to very many people with acne and hair growth. Whereas if you give injections or you use some sort of a peak and valley pharmacology agent and delivery system, you're more likely to get that. And you see a lot, and I see a lot of that with creams, and especially with people who are still receiving injectable testosterone.
Do you have patients that you prescribe other things besides these two types of pellets? Do you prescribe DHEA or pregnenolone, hydrocortisone, thyroid medicine, or vitamins and herbs?
That basically, especially in the early stages, because of the fact that we utilize more of a functional level of TSH to utilize as our parameter. We don't wait till patients get to 4.5 or 5.5 on their TSH before we start therapy. We put them through a certain number of questionnaires, which gives us some insight as to their thyroid function, and then correlate it to the TSH in their thyroid panel. So we use a lot of natural thyroid, within our practice, because we find that there are a lot of people that need both hormones, the T4 and T3, rather than T4 only. We find, unfortunately, that a lot of endocrinologists use T4 exclusively without exploring the possibility of using T3. And I think that the usage of T3 needs to be considered in a great number of individuals, because of the fact that there are a significant number of individuals that do have trouble converting T4 to T3 because through the action of the TPO enzyme. And if you have antibodies to that enzyme, even at low levels, your conversion of T4 to T3 is going to be affected. Usage of DHEA, I really discourage DHEA because it's like playing pachinko or a pinball game. It's a precursor. You don't know where it's going to go, and if you're giving DHEA along with testosterone, the testosterone need is, if it's satisfied, then the DHEA only has two other alternative pathways that it can take through its conversion to androstenedione and androstenediol, which can be converted to 16-alpha hydroxyestrone, which is a breast cancer stimulating estrogen, or it can go to DHT, which can cause hair loss, acne, and also prostatic has prostatic impact. So the usage of these precursors, which has been promoted by a number of anti-aging physicians, really I think is something that needs to be looked at in greater detail, because giving a little of this and a little of that and a little bit more of this, all being precursors. If you look how we create testosterone and estrogen, these precursors sit up top, and if you add precursors on top of the actual hormone, you're actually going to get adverse reactions because of the fact that my belief is that the body uses the hormones that it creates to do the good. The precursors are there to help the body make those hormones. Well, if you're already giving the hormone testosterone and estrogen, and you put more precursors in there thinking that, the DHEA is a little low, I'll give them DHEA. DHEA is only there to be able to help you implement the creation of testosterone, which has the majority of effects within the human physiology. So I tend to stay away from precursors. The people with adrenal fatigue, we'll use small. In addition to what we do, we may use small doses of hydrocortisone. But I emphasize small doses because once you make the physiology normal, the adrenal doesn't have to work as hard. And once it's recovered, if you're using just a small dose, it doesn't become dependent on the presence of hydrocortisone being there for a long period of time. So I think that we need to start thinking physiologically rather than thinking about the things that have been put up before us by the anti-aging individuals who promote giving a lot of precursors, because the precursors are basically there to help you make hormone, and you should go straight to the usage of those hormones. Not only that, but the usage of these precursors probably has been encouraged because they've been discouraged by the application of estrogen and testosterone in other delivery systems. Whereas if they were using a system that promotes continual presence of hormone, the usage of precursors would probably be eliminated almost completely, which I've found in my practice.
Mm-hmm. Thanks. I can't tell you how much I appreciate these explanations. What kind of screening do you put women through for breast cancer before you will use estradiol pellet?
There's been good literature, demonstrating that certain breast cancer survivors are still candidates for estradiol therapy. V. Craig Jordan, he published a paper out of the National Institute of Health in which he had a group of cells that from metastatic breast cancer that were tamoxifen resistant. and they were estrogen receptor positive, but these women, their cells had not responded to the tamoxifen. And what he did is he gave this group of cells small doses of estradiol. And I stress in that word, physiologic doses of estradiol. And what it did is it encouraged the development of apoptosis in these cells, and basically ordered them to kill themselves. So when we think about that, the human physiology, in the terms of human physiology, it makes sense. It's counterintuitive to what we've been teaching people, but in physiological thinking, if you think about why don't women in their 30s, mid-30s, who are genetically normal, have a much greater incidence of breast cancer, it's because in the proper ratio, if you give the proper ratio of estradiol to estrone, and the pellets are the only thing that create that. Pills, creams, and patches do not do that. And if you give the hormones in the proper ratio and it's at physiologic doses, it helps promote breast health rather than the encouragement of dysplastic tissue. And Craig Jordan in this study, elegantly demonstrated how estradiol induces apoptosis in even these quote unquote estrogen receptor positive cells by inducing apoptosis. And if we think about it, as women age, their incidence of breast cancer increases. What also is happening at that point is that they start losing the estradiol to estrone ratio. Not only that, but they also lose the level of estradiol production that used to be protective for them when they were in their 30s. So in essence, if we can recreate that physiologic state, then we should be able to reduce the development of dysplastic change in breast cancer cells. And as you probably know in the journals as well, testosterone helps decrease breast cell proliferation so that cystic disease of the breast is reduced in the presence of adequate testosterone. So with that premise, I did a study on 976 women, and I studied them for 10 years. And they were, the majority of them were 50 years old or older, and 70% of those individuals had been on other forms of estrogen replacement prior to using pellets. Out of 976 women over that 10-year period of time, I had one case of breast cancer. Statistically, I should have had 18 to 20. 6 years after the discontinuance of the study, I've only had 2 cases of breast cancer in a greater number of individuals, and each of these individuals developed the breast cancer within the first one in 6 months after starting pellets. So if you remember, cell duplication studies say that it takes 6 years for the cancerous cell to be, a cancer to be detected on mammography. So she developed hers and had hers before we treated her. And the second case of breast cancer, she was on the pellets for about a year. Once again, within that 6-year window. So if we're to take what Craig Jordan has said, is that we need to be rethinking what we think about estradiol. Estrogen in breast cancer survivors, and apply some of the research that I personally have done. Then screening individuals for estrogen replacement therapy, we do it as if, first of all, we explain to the patient that there's always a chance of recurrence of the tumor, and that that the present thinking says that estrogen might promote it, and we give them the opportunity of looking at the literature that we have, some by William Kreisman from the University of South Carolina, who says that estrogen replacement therapy in breast cancer survivors should be routinely done in certain individuals to protect their cardiovascular status. Philip DeSaya out of the University of California, Irvine, Chairman Emeritus of the Department of Gynecological Oncology, he basically says the same thing, is that there are certain individuals who have had breast cancer that they feel very strongly should be given estrogen once again. And I usually follow their parameters, but I always give the patient the choice, because you can always use testosterone to help them relieve some of their symptoms. And it does, in my studies, it isn't aromatized to estradiol to any significant degree to where their estrogen levels go up at all. But they feel better, they can think better, they have more energy, and they basically feel greater vitality. So we will individualize the therapy to each individual, but everyone that comes in who's had breast cancer, we take especially a very special time with them as well to basically go through literature that we have, and we actually give them the literature to help them make up their minds as to whether or not they want to pursue estrogen therapy or just testosterone only.
Your explanations actually demonstrate why you're known to be a giant in the field. People flock to you from all over. Your results speak for themselves. You're so well-spoken. You explain the reasons that things are happening, why people are seeing improvements. You have decades of experience in titrating up and down the doses so that the patient doesn't have side effects, that can stay stable. You've been able to reproduce physiology. You found the two hormones that are the end hormones and not giving precursors. Your results are just wonderful. I'm just so glad that so many people will have a chance to be exposed to your approach, and I'm sure there'll be many physicians wanting to learn your approach and to start using it more widely throughout the United States, and we have people involved in this seminar all over the world. So I can't thank you enough for sharing all that information with us. It was a real pleasure for me to listen to, and made fuller my understanding of the use of Soto Pellet pellets. And again, thanks very much for being with us.
Thank you very much for the kind words. I certainly appreciate that. And thank you so much for including me in the seminar. It's truly a pleasure, and hope to be talking to you in the near future.